Good morning, ladies and gentlemen. Today we're going to continue with the topic of surgery, thoracic traumas. The reality in life is that if we are in emergency, we're going to see most likely a lot of these lesions, and this is for the test of the real life and also for the test of the boards. In the United States, this is a prominent topic. The general principle concerning trauma is to assess what they call, or what we call, ABCDEs. The A is what we stand for airway, or support for the airways, making sure the person has a permanently airway access. There is no obstruction in the nose or in the mouth. The B stands for breathing, meaning that the person should be breathing properly, and we have to make sure the person, we take a resuscitation matters if the person doesn't have the breathing, if we are on time. The C stands for the circulation, and likewise, once we have addresses the A and the B, we go to, let's say, cardiopulmonary resuscitation, which goes together. We go with a chest, a fist into the chest, which provides equivalent energy to approximately 200 joules to reactivate the circulation. Because if we don't have a defibrillator on hand, if we have the defibrillator on hand, we just generally come to the defibrillator. Is non-synchronized because we don't have any rhythm of baseline. I just simply clear the space, everybody's clear, and we turn in the machine and produce the continuous shocks to resuscitate the patient. So we have A, B, C, then D. In D, in general, we're talking about any disability that the patient may have. We explore the neurological exam, if there is any Glasgow coma scale condition, or of course there is a cranial nerves or motor or sensory damage. And the E in general refer to the environment. For example, if it is cold, most frequent these patients can come with the equivalent to a shock, and so sometimes it's not infrequent to have a patient very cold, so we provide blankets, so we can provide this kind of additional support. Now, having said that, let's say how is the most common frequent scenarios that come to these boards. Let's say, for example, a case of a children, 8 years old, who was riding in the motorbike of his father without a helmet, and suddenly both had an accident and fly over for 20 feet until hit over the pavement, basically. And the emergency people, the EMTs, emergency medical technicians, bring this patient. When you come to you, you're going to take care of the kid. The children has a deviation of the nasal septum. It's completely filled with blood. There seems to be some damage in the airway, as evidenced by the exceedingly distress in the high respiratory rate, the anxiety in the picture of the exam, and also because of the early cyanosis around the mouth. So what is the next step? So the next step, we go with the basic principle, airway. And the airway, in this case, when there's a suspicion of fracture in the middle of the face, generally can be compromised. Meaning that when we're going to try to access, even if we would like to intubate the patient, there is a loss of anatomy. So, but this is a decision we have to take in matters of seconds. So, in children in general, we do not conduct cricothyroidectomy. We in general conduct tracheotomy. But tracheotomy usually takes more than 10 minutes. So we directly go with the finger, and because we had to gain some time, and we identify where is the depression between the thyroid and cricoid cartilages, and then in that point, which is an avascular point, we insert a very small needle, which is approximately 26 gauge, and then we start infusing jets of oxygen. Now the brain can stand the hypercapnia, but the brain cannot stand the hypoxia. So this will give us, let's say, 10 minutes, 15 minutes to just go and under it conduct the incision and place a tube during the tracheotomy. And this would save the patient, and we of course make the aspiration, we start closing any point that is bleeding, and we continue with the surgical part. But in this case, what is the next scenario is what actually determines saving the life of the patient. Now let's say another case is a 65 years old man who was painting, and suddenly he falls, and when he falls over his right side on the chest, and when he comes to you, the patient has a mild or actually a lot of pain, but it is you take an x-ray and you identify there is a rib fracture. So in this case, they ask you what is the next step. Now for the rib fracture, we have to identify first of all the age of the patient. Contrary to what the clinicians do, the clinicians just in general focus what is the patient history? Is he smoking? Does he has a cholesterol history? Does he has a bronchial asthma history? He has any diabetes? In the case of surgery, they are just very straightforward focus on the mechanism of action. Where was the fall? How far is the fall? 6 feet height. How the patient fall? Did he put his hands in an outstretched position? Did he hit directly into the floor with the ribs? And which size was that? And so in that focus, they identify, let's say, the rib was fractured. But the patient doesn't have pneumothorax. So the next question is, what do you do next? And they give you all sort of choices, from sending the patient home to providing hydration to providing pain medication, to all the different spectrum of choices. And again, in this case, we go again following the ABCs: airway, breathing, circulation. If the patient doesn't have any compromise anywhere and everything seems to be stable, the patient has a pretty normal breathing, normal frequency, everything is functioning, however, the patient doesn't have obvious any shock, the blood pressure is normal, the heart rate is normal, the next step in this case would be to admit the patient. And to assess the pain, we will not conduct any Tylenol or we give not morphine, any depression of this respiratory center. We'll go straight into blocking the nerve, and that will be the next step in the response. So we block the nerve and we observe the patient, we monitorize the patient very carefully, tending loving care in the way that we say, one-to-one with a nurse, with a monitor, that we can actually see how is the blood pressure, how is the heart rhythm, how is the function, the respiratory function. So this is in general the scenario. Now the same patient instead comes later, the nurse tells you suddenly that the patient is having a sudden decrease in the oxygenation. The pulse oximeter is dropping lower than 90. So with this antecedent, you had already a chest X-ray, you already knew there was a fracture, but it was a single fracture, and you, in your mind, said, this is not single fracture, this is a bigger condition because of the age of the patient. That's what makes a difference. So because of the age, you obviously consider the complications like pneumonia, like fibrosis, and all the different complications. One of them could be a late pneumothorax. And in this case, this is most likely diagnosis, straightforward. The next question, what do you do next? You immediately intubate the patient, you start producing a high pressure ventilation, or you open the chest for exploration. What do you do next? In general, what we do in this case, we understand that it's a pneumothorax. You identify clinically by auscultation, the absence of breathing sounds in that part of the lung, and technically you don't even need to just even go to another x-ray. You just simply go and insert a needle on the second intercostal space at the level of the mid-clavicular line, and from there the next step during the next 5-10 minutes, or you call with the help of the surgeon, or you insert yourself a chest tube to allow this collapsed lung to start expanding. And once you have the chest tube in place, you can produce the intubation and start producing positive pressure ventilation. Very important, never ever intubate the patient and start giving positive pressure ventilation in patients that you suspect or clinically had a trauma. And the mechanism of action is the mechanism of this trauma is the fracture of the rib. Even when it was apparently in place, its small movement for the normal breathing that the person has to keep was literally displaced. The rib punctures the pleura. The pleura is now open and it makes a pneumothorax. And that's how, because the pleural space doesn't have a negative pressure anymore, the lung collapses. So you have to just get the chest tube in place to allow this expansion again. Now, another scenario in this case, let's say it is a 25 years old gang member, as evidence for all these tattoos and coming. There is animosity. You come to the emergency room. Sometimes these people don't come alone. It comes like the whole gang all around, the two fighting gangs. Well, this gang member had a puncture an incision into the neck. And then observation, you see the marked ecchymosis, and there is crepitation in some of the part of the neck when you're palpating there. Now, in this case, immediately you should suspect there is, of course, a visceral trauma. And what is producing this air under the skin? What is going on? So, in this case, the diagnosis can be either a perforation to the esophagus or perforation to the trachea. Now, the questions go back again to essential. ABCs, airway, breathing, and circulation. Is the person on a respiratory compromise to lose the airway? And the answer to this is yes, because any lesion to the neck is potentially damaging to the airway and to the breathing of the patient. So, what is the next step? If the choices are intubation, you just go put endotracheal intubation. If the choice that you receive is conduct a observation of the, you can insert in exploration, una tracheostomy. You just want to observe the trachea, meaning you are going to explore with a tube. You're going to insert a tube to the mouth, and you're going to be progressively going inside and checking if there is any laceration of the trachea. Because if you go directly to the tube can come to the next thing. You're going to see a tube coming through the side of the neck. What was a partial laceration became a complete laceration. So if the choice is to explore, you go with explore, because you can even give oxygen during that exploration. If the choice is endotracheal, well, you don't have choices, because it's a matter of life and death, and basically you have to actually provide oxygen. In other ways, you could, back in other places, when we had this scenario, this is not what we do in America, but in other places people can insert a knife, literally insert a knife at the level of the manubrium of the sternum. Literally, we measure with our finger, sense the place where is these cartilaginous rings, and we detect where is the place between the two of them, and at that point we mark with our finger, come with a knife, and do not project the knife onto the neck, to the other side of the neck. We just simply puncture with a knife under that area, which is avascular, and then remove it, and then open the space for a tube. And actually, at some point you can insert a tube and let the surgeon finish fixing it to the skin. But again, this kind of measure is a last resource measure and has been in disuse. But in emergency, when you have the patient that obviously have a complete obstruction in the upper part of the neck, and there is no other choice, you have to save the life of the person. You get a pocket knife and boom, and you do that, and you save the life of the patient. That is survival for any kind of war scenario, gang scenario, things like that. So when you're a surgeon, when you're in training, you see many of those cases, all sort of punctures and gunshots and the nonsense that people get into violence. But here we are to save lives and to help people and say, well, let's bring the actual dialogue to helping each other, not to come to those kinds of extremes. Now let's go to another case. So let's say it's the same case even. 25 years old, has a trauma, the gang member, instead of having crepitus, you notice a mass. And the mass is growing rapidly, and it's rather soft mass. So you suspect which is a accumulation of blood because of puncture of some of the arteries and is or vein, and is accumulating rapidly. So this is also immediately emergency. You're talking to the patient. The rule is you're talking to the patient is alert or awake oriented, and time, place, person, that is a good indication, but that can change immediately in the next second. So you, even when you're talking, you're just going to say open your mouth and explore and remove any denture, any teeth that the person has, because this situation can change immediately to the next step. The person comes cyanotic, gets blue, and the person is like dying in front of your eyes. So you have to change that because you're talking to the patient at the very time of the trauma. You're removing, getting the airway, then goes to the breathing, and then what is the next step? The next step will be to conduct an endotracheal tube immediately to protect the airway and start ventilating, and then you gain time to do the next step, which is to open and actually close wherever is the vessel that is bleeding. Now, what is the next step in usually what other scenarios we have here? We have many types of lesions in the chest, but in general we can differentiate from the basic, the simple rib fracture, which usually is in place. When you take the x-ray, doesn't move, it's in place. You only see the little line that defines that is a fracture. In those cases, if young people, sometimes you can even observe, just admitting an observation just to make sure that everything is fine. If the person is elder, we saw already what we do, more tendon lower cane, you scale up the care with a one-to-one observation with a monitor. Now, the person can have two fractures, and when the two fractures are contiguous next to each other, this is a serious problem, because now the thorax, the breathing normally doesn't breathe normally, it has a paradoxical breathing, meaning when the person inspires, which the thorax should be coming out, instead of coming out, is coming in, because they are now two ribs and there are 2 points of support for the muscles. So it's paradoxical breathing. That's called frail chest. When we see the frail chest, we don't even need the x-ray. We already know that this is a multiple rib fracture, and we immediately, back in the time, we used to put some sandbag and we just press it with tape. That saved in some point the life, but it was also associated with a lot of fibrosis and pneumonias and long-term complications. In America, the next step, the treatment of choice, is immediately to produce intubation, endotracheal tube. Good morning, sir. And the endotracheal tube will start positive pressure, that the positive pressure will eventually expand the lung and help the person to heal. Now another lesion here, so we have simple rib fracture, multiple rib fracture, long trauma, long contusion, which is it's not a big deal. It's just the impact of the mechanism of the injury, the impact, the high force in an automobile accident against a wall, that kind of impact. Even if there is no fracture, the visceral suffers because they can be bleeding. It can have eventually predispose the tissue, which is soft, into complications such as pneumonia or fibrosis. So this is something that you can also have. So for the fractures, the long contusion, then we have also, of course, the pneumothorax. And the pneumothorax usually is just in one side. So you take the X-ray, you suspect it immediately because the polymnia of the patient. You know, the patient is an accident, comes with polymnia, bingo, you immediately almost say, well, chest tube. But before doing that, you just want to make sure if you have enough time, the patient is not that much polymnic, the oxygen is not that drop, the blood pressure is acceptable. The condition that defines that the patient is stable in this case is the blood pressure. Blood pressure less than 90 systolic is just right there in the borderline. If it's a little is above that, you can have some time to do the X-ray. If not, you just immediately go and insert the chest tube to save the life of the patient. Now let's say the patient has a pneumothorax. The pneumothorax, we saw already before that you never intubate. You just have to release the pressure from this trauma. Now, there is a difference between the pneumothorax. Some person comes with a pneumothorax and also come with abdominal pain. And when you explore, there was a rupture in the, it can be, let's say, in the viscous damage. The viscous damage can be to the right, for example, to the lung, or it can be to the liver, or into the left side, it can be to the spleen or to the lung. Or it can also be, if there is no open injury, it can be even to the heart. So the viscous traumas can be combined also with the pneumothorax, or even with tension pneumothorax. Now, the tension pneumothorax is a pneumothorax, but it's producing a displacement of the mediastinum to the other side. So it's getting high pressure, it's getting worse. And the way that you recognize that is by, of course, you're looking at the patient is polymnic in front of you, but also have a critical fissure, which is the distension of the jugular vein. And also you're taking the blood pressure, when you notice that there's a drop in the blood pressure. So immediately you recognize that it's not just a pneumothorax, a simple pneumothorax, but a pressure pneumothorax. And then you insert the chest tube and do the whole procedure. But let's say that you do the X-ray and you don't see the pneumothorax, and let's say that the patient has an abdominal bleeding because you identified that the spleen was taken during the accident. Let's say this motorbike crushed against the wall, literally, the patient fall. There was a rupture of the spleen, which is a very sensitive vital, not vital, an essential organ, but it's right there, and the spleen is bleeding, and you cannot leave that spleen there because they get into shock. The patient's blood pressure is dropping. So what do? You're opening the abdomen for exploratory and trying to close the vessels that are, you're going to remove the spleen basically. But when you're doing that, the anesthesiologist is telling you that now the patient is starting to drop the blood pressure, and you're containing already the bleeding. But how come it's getting into shock? Why? What's going on? And then the anesthesiologist is telling you that the patient is getting difficult to provide the oxygen. So in this case, you look at the patient and go again to the classical fissure of ingurgitation, of jugular vein distension. And when you see that, you don't have to even move forward. Now you have recognized that it's a pneumothorax that was not done not present in the X-ray, but it was there. It was a small fracture that didn't produce pneumothorax, but during the operation it opens and became a pneumothorax, an actual intention pneumothorax. So what do? You're closing the abdomen, you're going to just jump into the chest, and you're going to put the chest tube. It takes 10 minutes. What you're going to do? The next question is immediately you're going to see, since you are already in the abdomen, you're going to see the diaphragm descending over the peritoneal cavity. You're going to use one needle and puncture, decompress the diaphragm from the peritoneal cavity, and by doing this you immediately save the life of the patient. So this is another way of scenarios that can ask you what is the next step. The next step is just to puncture the diaphragm, and since you're already in the peritoneal cavity, and to save the life of the patient, because you're basically doing the equivalent to a chest tube to allow the lung to start to expand again. So the anesthesiology will continue bagging the patient with the oxygen, and they will eventually get better because you recognize this critical medical condition on time. Well, this is all for now. We're going to see the appendicitis, the next cases, the frequent cases, different scenarios where we have to do. And well, I hope you like it, and it could be at least it can be useful for some way, particularly if you don't practice emergency medicine oftenly. Thank you very much, and have a wonderful day. Thanks.